Can you see my screen? Hello, can you hear me? Okay, you can see the screen, right? Okay. So I will be discussing the week 3 WAP paper, but because of limited time, I won't go into in-depth detail much. So in the first question, chronic inflammation differs from acute inflammation as chronic inflammation persists for a long time. That is true. At last, it ends by complete resolution. So usually chronic inflammation, as it has ongoing fibrosis, doesn't end by complete resolution. But when we consider acute inflammation, the sequelae could be either complete resolution or abscess formation or going into chronic inflammation. Uh, yeah. Then, so this is true, this is false. Involvement of the immune system. We see involvement of the immune system in both chronic and acute inflammation. So this is false. Having ongoing necrosis. So as I said, chronic inflammation, there's ongoing necrosis, the inflammation and fibrosis as well at the same time. So this is true. Significant increase in WBCs in peripheral circulation is usually seen in acute inflammation. In chronic inflammation, there's only a mild increase in WBC count. So this is false. Then, regarding chemical mediators of acute inflammation, arachidonic acid production is facilitated by complements. So if you look at this here, you can see, now this is the arachidonic acid pathway. So C5A, which is a complement, facilitates this phospholipase to convert cell membrane phospholipids into arachidonic acid. So this is true. Steroids do not have an impact on the lipoxygenase pathway. This is false because, as you can see, steroids, they block phospholipase activity, thereby inhibit arachidonic acid production, which will inhibit both cyclooxygenase and the lipoxygenase pathways. Aspirin increases prostaglandin production. Aspirin is a cyclooxygenase enzyme inhibitor. So here in this COX pathway only, we get prostaglandins. So when we inhibit in this pathway, prostaglandins are reduced. So this is false. Thromboxane A2 is a potent vasoconstrictor. No, this is true. If you you'll have to remember some of the functions of certain chemicals. Now, if you look at this, PGE2 is mainly for pain, fever, and vasodilation. And then PGI2, prostacyclin, it inhibits platelet aggregation and causes vasodilation. And thromboxane A2, again, it's sort of the opposite action of prostacyclin. It does vasoconstriction and platelet aggregation. So this is true. Leukotrienes cause bronchoconstriction. This is again true. Leukotrienes do cause bronchoconstriction. Then, if you all have any questions, ask then and there, okay? Then, examples for paraneoplastic syndrome. So, what is paraneoplastic syndrome? It is when the symptom complexes in a cancer-bearing patient, the symptoms cannot be explained by either the local effects or the distant spread of the tumor or by the effect of secretion of hormones which are endogenous to the tissue. So in this case, Cushing syndrome in small cell carcinoma in lung, usually you don't get let's say steroids being secreted from a tumor in lung. So you cannot explain it from the secretion of hormones which is endogenous to the tissue. So it is considered as a paraneoplastic syndrome. Then episodes of hypoglycemia in an insulinoma, that you can of course explain how insulinomas, increased insulin levels can cause hypoglycemia. So it's false. Hypercalcemia due to bone metastasis of breast carcinoma again makes sense because of the metastasis. There's bone destruction and increased calcium levels in blood. So this is not a paraneoplastic syndrome. Migrated thrombophlebitis in pancreatic carcinoma, that's again paraneoplastic. And inappropriate ADH secretion in a glioma, that's also true. Then, chronic venous congestion results in the following conditions of the liver. So if you look at this, what happens in chronic hepatic congestion is basically this usually happens either in congestive cardiac failure or Budd-Chiari syndrome, where there's a compression of the hepatic veins draining the blood from the liver. So what happens is blood fills up in the central veins and the surrounding sinusoids of the hepatic lobules. And there's also hepatic hypoperfusion due to the left heart failure. This causes hypoxia. The hypoxia is relatively in the mid-zonal hepatocytes, and that is the zone 2. In the mid-zonal hepatocytes, the hypoxia is there, which causes fatigue change. And then, now, if you look at the hepatic lobule, it's like this. You have the central vein here, and here you have the portal triads. So, what happens is the area surrounding the central veins, usually that's where you see the necrosis, because at the cone of the lobule there's adequate blood supply, and in between, that is zone 2, there's relatively hypoxic area causing a fatigue change. So the necrosis is actually towards the here around the vein. So you get perivenular fibrosis and fatigue change in zone 2. But you don't see a neutrophil infiltration. That's usually in acute inflammation. Hemosiderin-laden macrophages are also, you call them heart failure cells. You see it in the lungs. So this is again false. And you don't see peripheral hemorrhagic necrosis. As I said, it's in the central area around the central vein. So this is also false. A is also false. Then, regarding ischemic heart disease, the subendocardial region is the most susceptible. This is true. The reason being, the subendocardial region is the area which has to be at the highest pressure. So because the pressure is highest at the subendocardial region, the failing heart, the ischemic heart, cannot pump enough blood into the subendocardial region during systole especially. So during diastole only, the subendocardium will get adequate blood supply. So in ischemic heart disease, mostly susceptible area is subendocardium. Then the most commonly affected vessel is the right coronary artery. This is false. It's the LAD, the left anterior descending artery, is the most commonly affected one. Then transmural infarction can cause left ventricular failure. Now, if you look at this, a transmural infarction is an infarction which involves the whole thickness of the myocardium. Okay, so this actually can lead to left ventricular failure. Then, multifocal microinfarcts occur due to occlusion of intramural vessels. Intramural vessels are the vessels within the wall, and when there's multiple microinfarcts throughout the intramural vessels, when there's a multiple blockages throughout the intramural vessels, you can get multifocal microinfarcts, and this can cause arrhythmias, which could be fatal. Like in this image, you can see there's diffuse multifocal infarction, and these can cause arrhythmias. So multifocal microinfarcts occur due to occlusion of intramural vessels is true. Don't cause arrhythmias, never. It does cause arrhythmias, which could be fatal. Then, a 54-year-old man who was diagnosed with emphysema was undergoing investigations for ankle edema, shortness of breath, and passed away from right ventricular failure. What can be observed in the post-mortem specimen? So, from the sounds of it, it sounds like the patient had emphysema, which led to hypoxia-induced pulmonary vasoconstriction. Thereby, he has got secondary pulmonary hypertension and then right-sided congestive heart failure. So it belongs to the group 3 of how pulmonary hypertension happens. It happens due to lung disease. So in the post-mortem specimens, now if we take the liver, we know there's a right-sided congestive heart failure. So because of the back pressure, there will be congested blood in the liver as well. And as I told you previously, there will be areas of necrosis, and zone 2 will show fatty change. So this fatty change is usually yellow in color, and the areas of hemorrhagic necrosis will be red in color. You call it the nutmeg appearance of the liver. So you do see red and yellow alternating patterns in the cut surface of liver. This is true. Then a small spleen, you usually get a large spleen because of the congestion of blood. There will be splenomegaly. So this is false. Fluid collection in the abdominal cavity, yes, it will be there because of now uh, the back pressure. There will be congested blood in the liver as well, and there will be ascites eventually. Right ventricular hypertrophy is also correct. Now, because there's hypertension in pulmonary hypertension, the right ventricle has to pump against a higher pressure, so it will be hypertrophied. Then frothy exudates in cut surface. I'm assuming this is in the lung. So you usually don't get frothy exudates in the cut surface in the lung in emphysema and pulmonary hypertension. It's usually in pulmonary edema that you get frothy exudates. So what you will see is you will see bullae in the lungs because of emphysema, but not frothy exudates. Then the next question regarding atherosclerosis, fatty streaks begin to appear in childhood. This is true. And then it affects arterioles. Usually, atherosclerosis does not affect arterioles. What it affects large to medium sized arteries. So this is true. This is false. Then thoracic aorta is more commonly affected than abdominal aorta. Usually, what is affected is the infrarenal abdominal aorta. That is also around the origin of the intercostal and lumbar arteries. Thoracic aorta is the involvement of the thoracic aorta is unusual, but if the patient has diabetes, you can see that as well. So it is not more common than abdominal aorta. Then tunica media of the arteries are not affected. This is also false. Initially, it is the tunica intima affected, but later the tunica media will also be affected by atherosclerosis. Then neutrophils play a role in the pathogenesis. Now, basically, what happens is in atherosclerosis, there will be an inflammatory reaction. So there will be neutrophils, there will be lymphocytes and macrophages as well, and there will be a fibrous component in the atherosclerotic plaque as well. So neutrophils play a role in pathogenesis is again correct. Then regarding pathological changes seen in the heart. Fibrosis of the chordae tendineae occur in acute rheumatic carditis. Now, if you see in acute rheumatic carditis, you won't see fibrosis. Usually, repeated attacks of acute inflammation, then thereby leading to chronic inflammation, can cause fibrosis, but not in the acute condition. Large friable vegetations are seen in acute infective endocarditis. This is true. Usually, if you look at this, the vegetations in infective endocarditis are large and friable, and they can sort of dislodge and migrate and thereby cause septic abscesses, embolized abscesses. But when we look at the rheumatic vegetations, they are pinpoint like pinhead sized, 1 to 3 millimeters in size, and they are firmly adhered. Because of that, they do not embolize. So B is correct. Then C, embolization in acute rheumatic carditis, it's false. As I said, the pinhead sized rheumatic vegetations are firmly adhered, so they do not embolize. Then ring abscesses in acute infective endocarditis. This is again true. Usually, there can be abscesses formed around the valve rings in acute infective endocarditis. And valve rupture in infective endocarditis, this is again true. As a complication of infective endocarditis, the chordae tendineae connected to the valves can get ruptured, or the valves itself can get ruptured. Going on to the next question. Regarding aneurysms, it's a temporary dilation of the vessel. Now, What an aneurysm is it could be either congenital or acquired, but it's permanent and localized abnormally dilated blood vessel. So it's permanent. It could be a blood vessel or the heart being abnormally dilated, and again, it could be congenital or acquired, but it's permanent. So this is false. Associated with Marfan syndrome, Marfan syndrome is a connective tissue disorder. So usually in connective tissue disorders, because the connective tissue is not that strong, the integrity is minimal. There could be sort of weakenings in the walls of the blood vessels, which lead to aneurysms. So this is true. Hypertension is one of the most important cause of aortic aneurysms. This again is true. Yes, the reason being hypertension can cause ischemic changes in the wall and thereby weaken the strength of the wall of the blood vessels and thereby cause dilatations of the blood vessel. Then, abdominal aortic aneurysm is commonly seen at a suprarenal location. Usually, abdominal aortic aneurysms are seen infrarenally. So, this is false. Then, berry aneurysm can be present at birth. Berry aneurysm is considered congenital. It usually happens in the circle of Willis, but it's not present at birth. Because of that, this is false again.
Nangi, excuse me.
Oh.
මේ ඔය abdominal aortic aneurysm එක infrarenal location එක වෙන්න මොකක් හරි ස්පෙෂල් හේතුවක් තියනවද?
එහෙම නම් මම දන්නේ නැහැ මම බලලා කියන්නේ ඔයාලට.
නෑ අපි අර ගොඩක් වෙලාවට කතා කරන්නේ දේව suprarenal එනවා කියලානේ මෙතන infrarenal වෙන්නේ ඇයි කියලා.
Hello.
හරි හරි කමක් නෑ. ඔය බලලා කියන්නකෝ.
හරි මම බලලා කියන්නම්.
හරි.
Sorry. ඊළඟට the 10th question regarding pneumonia. Lobar pneumonia causes interstitial inflammation. So usually we see interstitial inflammation in interstitial pneumonia, not in lobar pneumonia. This is false because of that. In lobar pneumonia, in the stage of congestion, local physical signs are easily elicited. So we know in lobar pneumonia there's 4 stages. First is congestion, then red hepatization, gray hepatization, and resolution. Usually the local physical signs are easily elicited in the red hepatization, not during congestion. This is false. In bronchopneumonia, a neutrophil-rich exudate infiltrates the bronchial wall. This is correct in so basically there's inflammation in the walls of the bronchioles. Lungs affected by lobar pneumonia heal by widespread fibrosis. Now, if you remember, in the resolution phase, what happens is there are these digestive enzymes which digest the exudates, and some are expectorated, and sometimes there can be a little bit of fibrosis as well, but it is not widespread fibrosis. So, because of that, this is considered false. Then bronchiectasis is a common complication of bronchopneumonia. This is true. So bronchiectasis is basically there's a dilatation of the bronchioles, and that can happen if there's a severe or prolonged bronchopneumonia, sort of obstructing the bronchioles and causing dilation of the bronchioles. Then on microscopy regarding COPD. So if we look at this now, COPD, there's 2 entities. Now we talk about emphysema and chronic bronchitis. So in emphysema, the microscopy will show destruction of alveolar walls without fibrosis, and there will be enlarged air spaces. You call them bullae. And the number of alveolar capillaries will be diminished, and there will be loss of septate, causing deformation of the terminal respiratory bronchioles. And in chronic bronchitis, there will be an ulcerated inflamed epithelium, squamous metaplasia leading into dysplasia, hypertrophic mucus glands, and fibrosis of the wall. So if you go into the question, smooth muscle hyperplasia and peribronchial fibrosis occurs when chronic bronchitis affects small airways. So that is true. There is fibrosis of the walls, and there is also hypertrophic mucus glands, hyperplasia. Sorry, with the hypertrophic mucus glands, you will also see smooth muscle hyperplasia as well. So this is true. Then, smoking is the main cause for squamous metaplasia of airway epithelium. That is also true. Ulcerated and inflamed epithelium is seen in chronic bronchitis. Again, yes. In emphysema, you will see large abnormal bullae. Yes, I said it previously. Fibrosis is the main pathological process causing emphysema. Now, I told you there's no fibrosis. There won't be any fibrosis in emphysema, so this is false. Then, regarding tumors of the pleura, primary tumors are primary tumors are more common than secondary. Usually, secondary tumors which have been metastasized to the pleura are more common. For example, breast cancers and lung cancers can metastasize, so this is false. Then, solitary fibrous tumors are aggressive malignancies. Now, solitary fibrous tumor is a benign condition of the pleura, so it's not that aggressive, it's usually small in size as well. This is false. Asbestos only increases the risk of lung cancer, but not the pleural cancer. Actually, asbestos increases the risk for mesotheliomas. That is a type of pleural cancer, so which is again malignant. So this is false for both lung and pleural cancers. Asbestos increases the risk. 5-year survival rate of mesothelioma is around 80%. As I remember, the survival rate for even 1 year after getting a mesothelioma was like 50%, as I remember. So it was very high. So even within 1 year, there's a high risk of dying. So this is false. For 5 years, survival rate is 80% maybe. Then mesothelioma metastasized to the hilar lymph nodes. Now, usually the metastatic spread from mesotheliomas are to the hilar lymph nodes and the liver. So this is true. Then, regarding bronchiectasis. So, bronchiectasis occurs due to persistent infection in the childhood. This is true. I told you previously, because of persistent infection, there can be blocks in the bronchioles and thereby dilations of the bronchioles. So this is true. Dilatation of the distal alveoli is a major pathological finding. The alveoli are not dilated in bronchiectasis. It is the bronchioles that are dilated. So this is false. Involvement can be seen up to the pleura. Is if you look at even in these how would you say these radiological images, you can see the involvement up to the pleura. So this is true. Ring shadows on lower zones are a recognized radiological abnormality. This is again true. What you see is tram track and ring signs in bronchiectasis. That's also in a particular type of bronchiectasis called cylindrical bronchiectasis. You see tram track and ring signs. Then cerebral abscess is a non-complication. Again, so bronchiectasis can lead to abscess formation within the lungs, which can also embolize and go into the brain and form cerebral abscesses. This is true. Then, in gastric adenocarcinoma, Leionitis plastica indicates a bad prognosis. So, Leionitis plastica is the diffuse type of gastric adenocarcinoma where you get a leather bottle appearance. It usually has a worse prognosis than the intestinal type because it's very diffused. It involves the whole stomach and but when you consider the intestinal type, it's usually solitary, like it could be exophytic or ulcerated likewise, but Leionitis plastica involves the whole stomach. So this is true. Obesity is a risk factor for non-cardiac cancers. Usually obesity is a risk factor for cardiac cancers, that is in the gastric cardiac region. when you get the carcinoma, we call it a cardiac cancer. Obesity is a risk factor for cardiac cancers. And this is false. Then, dyspepsia is a feature of early gastric carcinoma. Usually, early gastric carcinoma presents with symptoms of peptic ulcer disease, so dyspepsia. This is true. Then, APC gene mutations play a major role in hereditary diffuse type. Now, usually, in the diffuse type, you get CDH1 mutation, and in intestinal type, what you get is the APC gene loss of function mutations and beta catenin gene gain of function mutations. This CDH1 is the gene responsible for coding E-cadherin. So, for beta catenin, it's intestinal type. E-cadherin is diffuse gastric cancer type. So, this is again false. A positive Troisier sign can be seen. Now, Troisier sign is when you get a hard palpable left-sided supraclavicular lymph node, as in this. So this, you also call this the Virchow's node. Usually, gastric cancer metastasis happens to the left supraclavicular lymph nodes, and you get a positive Troisier sign. So this is true. Not only not only gastric adenocarcinoma, several cancer types can metastasize and you metastasize to the left supraclavicular lymph nodes, like even breast cancer can. Then, in cirrhosis, pathogenesis involves deposition of type 4 collagen. Okay, so first I'll tell you the pathogenesis of cirrhosis. So basically, what happens in cirrhosis is there's chronic hepatocyte damage, and because of that, you will get a chronic inflammation in the liver. So what happens is there will be fibrosis as well as regeneration at the same time because it's chronic inflammation. So the hepatocyte damage and certain toxins produced, the certain toxins which act as the trigger for the hepatocyte damage themselves can produce certain cytokines and reactive oxygen species, which will thereby stimulate stellate cells in the space of disc. Now, stellate cells, when they get stimulated, they get converted into myofibroblast-like cells, and thereby they deposit type 4 collagen in the space of disc. They deposit type 1 and 3 collagens. I'm sorry, it's type 1 and 3 collagens being deposited in the space of disc by stellate cells. So usually what they have is in the space of disc, they have type 4 collagen. But in cirrhosis, they get type 1 and 3 collagen. And thereby, so basically you will get fibrosis in the liver. And there are also surviving hepatocytes. So the fibrosis happens surrounding the surviving hepatocytes, and the hepatocytes themselves will try to regenerate. And because of that, you will see fibrosis in cirrhosis with regenerative nodular appearance in the liver. So because of this fibrosis, liver is not enlarged, it's actually shrunken. So because of that, B statement is wrong. A as well, pathogenesis involves deposition of type 4 collagen in space of disease strong. Usually they have type 4, but because of the action of the stellate cells, it gets replaced with type 1 and 3 collagen. Then, chronic hepatitis A infection is a predisposing condition. Usually, hepatitis A and E cause acute hepatitis, but hepatitis B, C viruses are the mostly common ones to progress into chronic hepatitis. So this is false. Then, portal hypertension is due to compression of central arteries or due to perivascular fibrosis. Now, portal hypertension happens due to compression of the central veins. Actually, there's nothing called central arteries. So this is false. Apart from that, the blood flow is resistant within the sinusoids as well. Because of this high resistance and also because of the compression of the central veins, you get portal hypertension. Then, Excessive scar resorption due to cessation of alcohol normally reverts vasculature to normal. Now, this is actually false. You get fibrosis in the liver in cirrhosis. This fibrosis doesn't go away completely, even if you stop alcohol usage, or even if the hepatitis viruses are taken away from your blood. Uh, there won't be complete reversal. So this is false. There will be some reversal, but not 100%. Then, regarding pancreatic and biliary system, acute cholecystitis is a complication caused by gallstones. This again is true. Acute cholecystitis is almost always associated with gallstones. And these gallstones can be either made up of cholesterol, or it could be made up of pigments like bilirubin. So, pigmented gallstones have high levels of bilirubin, or they could be mixed as well. So, gallstones have high cholesterol content, is true. Carcinoma of the body of the pancreas causes obstructive jaundice. This actually, now we know it's the head of the pancreas, which the common bile duct goes through the head of the pancreas. So when there's a cancer in the head of the pancreas only, you get obstructive jaundice. This is false. Um, then chronic use of alcohol causes calcification of the pancreas. Now we know alcohol usage is a cause for acute pancreatitis. So when the patient is chronically on alcohol, there can be repeated bouts of acute inflammation, and there can be severe repeated damage to the pancreatic acini cells. And because of the necrosis, later they can get calcified. So this is true. Increased serum amylase is a feature of acute pancreatitis. This again is true. Serum amylase in the acini will get released into the blood in acute pancreatitis because the cells are getting damaged. Then, regarding colorectal carcinoma, carcinogenesis is a multi-step process involving progression from an adenoma to an carcinoma. This is true. Adenocarcinoma is indeed the commonest type. That is also true. NSAIDs have a protective effect. Now, this basically what happens is when you give NSAIDs, they regress the polyps in certain familial adenomatous polyposis conditions. The reason being the cyclooxygenase 2 enzyme is highly expressed in most of the colorectal cancers. So when you give NSAIDs, they inhibit cyclooxygenase 2 and thereby cause regression of the polyps. So it does have a protective effect. Altered bowel habits are more common with left-sided tumors. This is again true. Then carcinoembryonic antigen is useful to monitor treatment and early detection of metastasis. So CEA is a tumor marker which we use in colorectal cancers, but not only in colorectal cancers, this also in cancers of the stomach or pancreas, but not only in cancers as well, even in pancreatitis or other chronic renal diseases, you will see high levels of CEA. So because of that, we don't use this as a screening test, but we do use this to see if the treatment is working. So we use this to monitor treatment and to see if there's any metastasis. So this is true. Next question regarding pathogenesis of glomerulonephritis. So circulating immune complex deposits show linear deposition. If we look at this diagram, so you can see there are mainly two types of immune complexes. There are circulating immune complexes and in situ immune complexes as well. So these circulating immune complexes cause granular immunofluorescence. And this in situ type can cause both granular immunofluorescence as well as linear immunofluorescence in different conditions. So I think when we go through the question, we can see the conditions. Circulating immune complex deposits show linear deposition is false. As I told, in situ ones do cause linear deposition, but not the circulating ones. In situ immune complex deposits show granular deposition. yes, in situ can show both granular and linear deposition. Usually in membranous nephropathy, the in situ immune complexes go and deposit in the subepithelial com- subepithelial region and thereby cause granular deposition. But when in situ and immune complexes go and uh, bind as antiglomerular basement membrane antibodies, what happens is you will see linear immunofluorescence. So this is true. Subepithelial immune complex deposition causes membranous glomerulonephritis. Uh, so, as I told you previously, membranous nephropathy or membranous glomerulonephritis causes a granular immunofluorescence by in situ binding of immune complexes, and the immune complexes are deposited in the subepithelial region. So, this is true. Mesangial cells produce inflammatory mediators. This is again true. The reason being, so there are certain types of glomerulonephritis where there's mesangial proliferation. And like in mesangial proliferative glomerulonephritis and membranoproliferative glomerulonephritis, in those conditions, the mesangial cells do produce inflammatory mediators and thereby cause mesangial proliferation. Then, macrophage procoagulant activity plays a role in crescent formation. This again is true. Now, crescents are formed by basically proliferated parietal epithelial cells. So, what happens is there are breakages in the basement membrane of the capillaries in the glomeruli, and thereby it causes leaking of plasma protein and fibrin into the Bowman's space. And because of the plasma proteins, they stimulate the parietal epithelial cells to proliferate. And at the same time, the infiltrated monocytes and macrophages also get stimulated by these plasma proteins and contribute to crescent formation. Then, pathological changes that can be seen in kidney in benign hypertension. So, if we look what benign hypertension causes to the kidney, basically we know in benign hypertension we see hyaline arteriosclerosis or fibroelastic hyperplasia. And now in hyaline arteriosclerosis, we know the lumen of the arterioles are smaller. Because of that, there will be patchy of diffuse hypoxia, and thereby there will be atrophy. And so basically atrophy in the tubules. There will be atrophic tubules, and because of this ischemia, there will be interstitial fibrosis. And also in the glomeruli, we will see collapsing of the glomerular basement membrane, periglomerular fibrosis, and glomerulosclerosis. And this eventually, with time, will lead to reduced functional renal mass. So, if you look at the question, fibrinoid necrosis of small arteries is actually not seen in benign hypertension, it's seen in malignant hypertension. If you look at this, basically in malignant hypertension, you will see fibrinoid necrosis, intravascular thrombosis, and hyperplastic arteriosclerosis. And this will give rise to this flea-bitten kidney, where you get these petechial hemorrhages on the surface of the kidney. So again, petechial hemorrhages is not seen in benign hypertension. B is false. Sclerosis of the glomerular tuft, I said previously, there's glomerulosclerosis in benign hypertension. So this is true. Papillary necrosis, again, it's not seen in benign hypertension. You see papillary necrosis in diabetes, not here. Tubular atrophy, again, yes, as mentioned previously, it is there. Then, regarding prostate carcinoma, Gleason scale is used for grading. This is true. Now, in prostate carcinoma, grade and the stage are the most important for prognosis. And grading is done by Gleason scale, staging is done by TNM staging. Okay, this. So this is true. Large duct type has a worse prognosis than small acina type. This again, usually small acina type is the more common one, but large duct type is the more aggressive one. So it does have a worse prognosis. The answer I've given is wrong here. Then normal PSA levels can exclude prostatic adenocarcinoma. Now, PSA is a tumor marker, prostate specific antigen. Actually, it's not cancer specific, it's organ specific. So, not only in prostatic adenocarcinoma, even in benign prostatic hyperplasia, in instrumentation of the prostate, or even in ejaculation, you can see high levels of PSA. But very high levels of PSA will be suggestive of a malignant condition of the prostate. Said that there can be poorly differentiated prostatic adenocarcinomas which do not secrete PSA. So, because of that, you cannot exclude the prostate adenocarcinoma even though the PSA levels are normal. So, this is false. Then, androgen dependent tumor, this is correct. Prostatic carcinoma, adenocarcinoma is androgen dependent. So, because of that, for therapy, we can give certain hormonal therapies like we can give estrogens, and sometimes we also give luteinizing hormone releasing hormone agonists likewise. So, this is androgen dependent. Then, radical prostatectomy is done in the early stage of the disease. Now, usually, this is correct. You can do radical prostatectomy in the early stage of the disease. But when it comes to the late stages, there's no point in doing a prostatectomy because now it's already spread. So, what you would do is usually radiotherapy, but you can do transurethral resection if there's any sort of obstructive symptoms obstructing the urethra. In such conditions, you can do a transurethral resection. Then, regarding urothelial tumors. Now, urothelial tumors are basically carcinomas occurring due in a transitional epithelium. So, here, multiple tumors develop along the urinary tract. This is true. When you consider urothelial tumors, due to the field effect of carcinogens, there can be multiple primary tumors along the urinary tract. That is, the whole urinary tract is at the same time exposed to the carcinogen. Because of that, there's multiple tumors at multiple places around the urinary tract. They are not secondary tumors. So this is true. Then they are etiologically linked with schistosoma infection. Now, if you look at cancers in the bladder, there's three types. We talk about three types: urothelial carcinomas, squamous cell carcinomas, and adenocarcinomas. Urothelial carcinomas arise from the transitional epithelium. Squamous cell carcinomas are caused due to schistosoma hematobium. So the statement saying urothelial tumors are etiologically linked with schistosoma infection is false because schistosoma gives rise to squamous cell carcinomas, and these are made up of transitional cells. Then they lead to the presence of dysmorphic red blood cells in urine. There can be red blood cells, but they are not dysmorphic. Usually, if it's dysmorphic RBC, it's a pathology in the glomerulus. So this is false. Hydronephrosis is a presenting feature. This, yes, can be because there can be obstruction in the urinary tract causing hydronephrosis. Low-grade tumors have a papillary configuration that again is true. Then, regarding beta thalassemia, the majority of the mutations are deletions. Now, how I remember this is beta thalassemia is by point mutations. These the P, simple P and the beta looks alike, and alpha thalassemia is due to deletions. So the majority of mutations are deletions is false. It's due to point mutations. Then basophilic stippling in red blood cells is present. That is true. If you look at this in the blood film, these are the changes you see in thalassemia. You will see hypochromic microcytic red blood cells, target cells. There will be nucleated red blood cells, the immature ones, certain Hubble-Jolly bodies, and basophilic stippling, and sometimes a wolf ball appearance. That is, now in thalassemias, we know there are abnormal hemoglobins being produced. Golf ball appearance is due to this HBH, a certain type of hemoglobin being produced in alpha thalassemia. These HBH inclusions cause golf ball appearance. So, coming back to the question, basophilic stippling in RBCs is present is true. That's mainly, though, it's mainly in beta thalassemia trait. Then HbA2 is increased in beta thalassemia trait. Now, this, I told you there are certain abnormal hemoglobins being produced. And the reason is beta thalassemia is when there's the beta globin synthesis is not happening properly. So, because of that, there will be an imbalance of extra additional alpha chains will be there relative to the normal beta chains. So, then what happens is the alpha chains will go bind to other globin chains and form different types of other hemoglobin types like HbA2. So, in beta thalassemia trait, again, HbA2 will be increased. Then, hemoglobin type quantification at birth confirms the diagnosis. Now, now what I said is, so basically, it takes 6 to 9 months for the HbF, that is the fetal hemoglobin, to be switched to HbA, that is the adult hemoglobin. So, because of that, at birth, the baby will have good hemoglobin. It takes 6 to 9 months for the patient to present with the symptoms. So, hemoglobin type quantification at birth will not confirm the diagnosis because the patient doesn't have enough HbA anyways. Then, red cell count is disproportionately higher relative to hemoglobin. Now, this is again true. You should know that in iron deficiency anemia, there's this relationship where we say the red blood cell count into 3 is roughly equal to the HB count, and then the HB count into 3 is roughly equal to the PC. This is in iron deficiency anemia. This relationship is not there in thalassemia. In thalassemia, this RBC count will be disproportionately high relative to the hemoglobin count. This is one way to differentiate between iron deficiency anemia and thalassemia actually. So this, the final statement is true. Then cryoprecipitate contains, so what cryoprecipitate contains is there's factor 8, there's factor 13, there's 1 Willebrand factor, fibrinogen and fibronectin. So pretty straightforward question. This is not there. These are there. 13, 8, VWF, fibrinogen and fibronectin are there. Then the following diseases and the characteristic feature or investigations findings are correctly matched. CML is chronic myeloid leukemia. There you do get the Philadelphia chromosome. This is correct. Essential thrombocythemia, which is a myeloproliferative condition. These are the 3 mutations that you see: JAK2, calreticulin, and MPL mutation. So MPL mutation is correct. So in these 3 types of myeloproliferative conditions, remember that polycythemia vera only has JAK2 mutations. The other 2, in addition to JAK2, you also get calreticulin and MPL mutations. Then myelodysplastic neoplasms, they do not cause splenomegaly. That's false. Then Fanconi anemia, that's a bone marrow failure condition. You do see an aplastic bone marrow. This is true. Then polycythemia vera, calreticulin is not there. Calreticulin is seen in essential thrombocythemia and primary myelofibrosis. So that's false. Then regarding anaphylaxis. So if we look at how we diagnose, basically how we suspect anaphylaxis, if we look at this, it's basically with the skin involvement. If the patient has either of these airway breathing or respiratory compromise, or a circulation problem, or other system involvement like severe GI system involvement, we say it's an anaphylaxis. So the statement saying skin manifestations are rare is false actually, because skin manifestation is the commonest thing you see in an anaphylaxis. Around 95% of the time you see a skin manifestation with either of those airway, breathing, or other systems like GI system involvement. This is false. And then, so there's another thing. So yeah, and then intravenous adrenaline is the initial treatment. Mm, this actually, you do give intravenous adrenaline, but considering the initial treatment, in management, the first thing that you have to do is basically ABCDE management, the DRABCDE management. So because of that, you can't consider this as the initial treatment. Then elevated serum tryptase confirms the diagnosis. This is true. In anaphylaxis, serum tryptase levels are elevated. A low blood pressure is necessary for diagnosis. Again, a low blood pressure is not definitely necessary. As I said, it's either it could be um, it could be involving any of these systems. So with the skin involvement, the patient can have at least a respiratory compromise, or it could be a circulation problem with hypotension, or it could be other system involvement as well. So either that way, or there's another way where we can suspect anaphylaxis. Let's say the patient has been exposed to a non-allergen. Now in the previous condition, now the first thing I told you was, now this I'm sorry, the first thing I told you, in that situation, maybe they don't know that there's a particular allergen causing anaphylaxis. So maybe it's the first time presentation. So the patient might have a skin manifestation with either of those three system involvement. But let's say the patient knows that the patient has a certain allergy. So the patient is getting, now has got exposed to a non-allergen or some sort of a highly probable allergen. In that condition, what we diagnose is we need to have at least one of these three involved, at least a bronchospasm, or a laryngeal involvement, or a systolic blood pressure being less than 90, or a greater than 30% decrease from whatever that patient's baseline. So this is when there's a highly probable allergen or a non-allergen being exposed. So a low blood pressure is not necessary for diagnosis. Bradycardia is more common than tachycardia. That again is false. We know now in anaphylaxis, basically there will be vasodilation, increased capillary permeability, thereby leading to hypotension. So the body's compensatory mechanisms will try to increase the blood pressure somehow by inducing tachycardia. So tachycardia is more common. Then, regarding iron deficiency anemia, serum ferritin level is decreased. That is true. Serum ferritin is the storage form of iron in serum, so that should get decreased if you are deficient in iron. That is true. Then RDW is raised. Now RDW is the red cell distribution width. It is an indicator of anisocytosis, which is the variation in the red blood cell size. In iron deficiency anemia, there is anisocytosis. There will be like a high RDW because of that. Then TIBC is raised. Now TIBC, or the total iron binding capacity, is an indication of the transferrin levels. So the transferrin levels increase when the iron levels in the body reduces. So because of that, the TIBC is high. Then can cause koilonychia. Koilonychia is a nail change occurring in iron deficiency anemia. If you look here, you call it spoon nails as well. It's like a spoon should are depressed in the middle. So this is true. GI bleeding is the primary suspicion in a young male. Now, iron deficiency anemia is mostly commonly seen in females more than males. And even when a young male presents with iron deficiency anemia, your primary suspicion should be either a dietary deficiency or malabsorption. But if it's an older male, you have to definitely primarily suspect GI bleeding. So in a young male, GI bleeding is not that it's not the primary suspicion. Then regarding thyroiditis, subacute granulomatous thyroiditis occurs in post-viral infections. This is true. Antibodies for thyroglobulin is seen in Hashimoto. This again is true. Um, what happens is basically in Hashimoto's, it's the type 4 hypersensitivity. So, although there's antibodies for thyroglobulin, don't mix it up. Now, in Graves' disease, there's thyroid stimulating immunoglobulins, TSI. And in Graves, it's a type 2 hypersensitivity. But Hashimoto's is a type 4 hypersensitivity. It's mainly T cell mediated hypersensitivity, but you also see antibodies for thyroglobulin as well. Then, fibrosis extends outside the gland in Hashimoto's. This is false. You see fibrosis extending outside the gland capsule in Reeder's thyroiditis, not in Hashimoto's. In Hashimoto's, it's confined to the gland. Lymphocytic thyroiditis occurs in the postpartum period. This is also correct. It's postpartum thyroiditis is the same as lymphocytic thyroiditis. Thyroxine levels elevated in the early stages of thyroiditis. This again is true. The reason being in the early stages of thyroiditis because of the preformed thyroxine and hormones will be released into the blood. But with time, what happens is your thyroxine levels will drop. Initially, there's a transient hyperthyroidism. This is true. Then, in comparison to follicular carcinoma, papillary carcinoma of thyroid. Yes, has a better prognosis. The better prognosis is with papillary carcinoma. This is true. The prognosis is good even with isolated cervical node metastasis in papillary carcinoma. Occurs at an older age. Now, follicular carcinoma is the type which is presented at an older age. Papillary carcinoma can occur at any age. So this is false. Most frequently shows hematogenous spread. In follicular carcinoma, the metastasis occurs mainly through blood to lungs, bone, and liver. The lymphatic spread is rare. But in papillary carcinoma, mainly the metastasis is via lymphatics. So this again is false. Causes multifocal lesions. This is true. Papillary carcinoma causes multifocal lesions and RET-PTC mutation is seen. This again, if you look here, follicular carcinoma shows mutations in the RAS oncogene, and BRAF and RET-PTC are the mutations happening in papillary carcinoma. So this is true. Then, regarding renal complications in diabetes, diffuse glomerulosclerosis occurs only in diabetes. Now, this diffuse glomerulosclerosis is a glomerular lesion happening in diabetes, but not only in diabetes, you see it in hypertension and also in old age as well. So this is false. The lesion which is unique to diabetes is nodular glomerulosclerosis. You also call it Kimmelstein-Wilson lesions. It's only seen in diabetes. So Kimmelstein-Wilson lesions are pathognomic of diabetic kidney disease is true. Necrotizing papillitis is a recognized complication in diabetes. Yes, the reason being diabetic patients are highly susceptible to infection, so they can get necrotizing papillitis. Then, macrovascular disease does not contribute to diabetic kidney disease. Usually, now in diabetic kidney disease, there can be macrovascular changes like renal atherosclerosis, and hyaline arteriosclerosis, as well as microvascular changes like in diabetic microangiopathy. And also, there will be glomerular lesions. So, in diabetes, there can be one macrovascular disease lesions, there can be microvascular lesions, and glomerular lesions as well. So, this is false. Then, nephritic syndrome is a common manifestation. Usually in diabetes, there's nephrotic syndrome, not nephritic syndrome. Usually, nephritic syndrome happens in inflammatory conditions. Nephrotic syndrome is the manifestation in diabetes. So, this is also false. The diffuse glomerular sclerosis gives rise to nephrotic syndrome in diabetes. Then, pituitary macroadenomas. So, what are macroadenomas? They are when the size of the adenoma is more than 1 centimeters in diameter. So, A are more likely to be non-functioning than microadenomas. This is true, the reason being, now functioning adenomas are the adenomas which secrete hormones. Non-functioning ones do not secrete hormones. So you will not see symptoms until there will be sort of compressive symptoms due to compression arise later. So basically, only when the adenoma increase in size and become a macroadenoma, you will get compressive symptoms. Until then, in a non-functioning adenoma, you won't get symptoms. So because of that, macroadenomas are most likely to be non-functioning. But microadenomas, they present soon because of the functioning nature of them. So this is true. Then majority are prolactinomas. That again is true. Most of the time, lactotrophs are the cell types involved in these prolactinomas, and the most common presentation is due to galactoria. So this is true. Can give rise to bitemporal visual field abnormalities due to mass effects. Again, yes. The pituitary is just below the optic chiasma, so there can be compression of the optic chiasma causing bitemporal hemianopia. Can infiltrate neighboring tissues, indicating a malignant transformation. Macroadenomas can indeed infiltrate the neighboring tissues, but they are not malignant. They can invade, but they are not malignant. So this is false. Can present with hyperpituitarism as well as hypopituitarism. That again is true. Now, the reason being, the adenoma itself can secrete the hormones, or because of the adenoma, the surrounding pituitary tissue can get compressed and hypopituitarism can result. So this is true. Then, which of the following mechanisms are correctly matched with the example? Pharmacology section. Okay. Pharmacokinetic antagonism, adrenaline used in anaphylaxis. Now, adrenaline being used in anaphylaxis is actually physiological antagonism. So, what happens in there is, now in anaphylaxis, we get histamine causing vasodilation and increased capillary permeability and bronchoconstriction. What adrenaline does is, adrenaline goes and binds to the adrenergic receptors like alpha 1 in blood vessels and thereby cause vasoconstriction. Beta 1 in the heart can cause increased heart rate. Beta 2 in the airways cause bronchodilation. Likewise, so adrenaline goes and binds to some other sort of a receptor in which histamine does not act. So that is a physiological antagonism. Pharmacokinetic antagonism is when a certain drug will alter the pharmacokinetic parameters, like the absorption, distribution, metabolism, elimination is altered by one drug which affects the other drug. So this is false. Physical antagonism, charcoal used in paracetamol overdose, that is true. Charcoal is used as an how would you say in paracetamol overdose is basically a toxin. So what charcoal does is it gets absorbed to the toxins and antagonizes the action of the overdose. Then, chemical antagonism, tryptamine sulfate reverses the effect of heparin. It's actually not tryptamine sulfate, it's protamine sulfate. That is why it's considered false. Now, protamine sulfate and heparin, that reaction is chemical antagonism. There's an acid base reaction happening there. Tryptamine sulfate is not the one which should be here, it should be protamine sulfate. So this is false. Then competitive antagonism, atropine in organophosphate poisoning. So this is again true. In organophosphate poisoning, it goes and binds to the acetylcholine esterase. So then what happens is, now the acetylcholine esterase is not there to sort of uh, how do you say, degrade the acetylcholine. So the excess acetylcholine goes and binds to the receptors and gives the effect. So in competitive antagonism, you give atropine, which is a muscarinic antagonist. So it goes and binds to the receptors, competitively antagonizing with acetylcholine. So this is true. Physiological antagonism, this again, salbutamol in asthma is correct because salbutamol goes and binds to the beta 2 receptors in the bronchi and the airways and thereby cause bronchodilation. But yeah, so that is again physiological antagonism is correct. Then paracetamol and morphine are both analgesics. Compared to paracetamol, morphine has a higher analgesic efficacy. That is again correct. Morphine is at the latter part of the analgesic step ladder, whereas paracetamol is in the beginning. Ability to activate the descending inhibitor pathway, that again is true. Now we know both paracetamol and morphine, they act centrally. When we consider NSA, they are also analgesics, but they are peripherally acting. The difference in paracetamol and morphine is paracetamol inhibits COX. Morphine, they activate the descending inhibitor pathway. Then, lack of antipyretic activity. Yes, the antipyretic activity is there with paracetamol and NSAIDs, but not with morphine. So this is true. Ability to inhibit COX enzyme, that again, paracetamol has that ability, but morphine doesn't. And both paracetamol and morphine have the ability to penetrate the blood-brain barrier. They are centrally active. So this again is false. It's not only for morphine. Then, regarding sympathomimetics and their indications. So noradrenaline is a selective alpha 1 agonist with slight beta effects. So we don't give it in cardiac arrest. We give noradrenaline in conditions like septic shock because it binds to alpha 1 in blood vessels. For cardiac arrest, we have to give something with high actions on the beta 1 receptors. So this is not suitable. Noradrenaline is not suitable for cardiac arrest. It's given in septic shock-like conditions where there's peripheral vasodilation. Then dopamine for hypotension, yes, you can give. Dopamine has beta 1 effects with some alpha effects. So it has beta 1 effects. It can bind to the beta 1 receptors in the heart and cause tachycardia. So it's given for hypotension. Isoprenaline. Isoprenaline is a non-selective beta agonist. So it has both beta 1 and beta 2 effects. So that can be given for complete cardiac block again because beta 1 is there in the heart. Then salbutamol for premature labor. That is also correct. That's an indication for salbutamol because there's beta 2 in the uterus, which sort of goes and blocks the uterus. So it inhibits the uterine contractions. Then dobutamine, again, for cardiogenic shock, it is given. Dobutamine has beta 1 effects. So it goes and binds to the beta 1 receptors in the heart, so can be given for cardiogenic. Then, a 65-year-old patient with CKD, EGFR is 20, was recently diagnosed with hypertension. The suitable medicines for this patient. Mm, So here in such a question, you have to consider now several things in the question. So that's the age of the patient and a comorbidity with the EGFR as well. And the other disease is hypertension. So they're asking the medicine suitable for the patient. Now, amlodipine is a CCB. It is metabolized in the liver, and there's no problem with giving it in CKD. So you can give amlodipine. Bisoprolol, again, it's a beta blocker. Now, bisoprolol is not a first line for hypertension. And even in CKD, you can give bisoprolol. It's not a contraindication. You have to be cautious. You have to monitor the renal function and give bisoprolol. But it's not a contraindication. So you can give it, but it's not a first line for hypertension. If the patient has another cardiac indication, let's say something like heart failure or MI, you can give bisoprolol. But that's the reason why it's a bit doubtful, but it is suitable. It's not contraindicated. So I would take this as true actually. It's a bit doubtful though because it's not a first line for hypertension. Unless you have a cardiac indication to give bisoprolol, it's not taken first line. Then eplerenone, again, it's a potassium sparing diuretic. So when you give eplerenone, your potassium levels will rise. Because of that, in a CKD patient with EGFR being 20, eplerenone is contraindicated. So this is false. Indapamide is a thiazide-like diuretic, and if you remember, thiazides and thiazide-like diuretics lose their efficacy when the EGFR drops below 30. So you don't give it here. It's not suitable because the EGFR is 20. Then losartan, again, an angiotensin receptor blocker. In this condition, so usually we do give losartan. So it has a renoprotective effect. But because the EGFR is 20, you have to monitor the potassium levels and the kidney function and cautiously give it. But it's still, I mean, you can give it. It's not contraindicated. So this is again true. Then, regarding amiodarone, has an enormous volume of distribution. That is true. It has an extremely high volume of distribution, like 70 liters per kg. Half life is 72 hours. That's wrong. Again, it has an enormous volume of distribution as well as a very long half life as well. That's up to 100 days. This is false. Structurally similar to thyroxine, this is true. How I remember is that in amiodarone, there's this iod part, iod, like iodine. So I get this feeling when it's related to iodine, it's some sort of there's some sort of a relation to thyroxine. So amiodarone and thyroxine is structurally related. That's how I remember it. So just a clue. Then it it is a class 1 triple A. I'm not quite sure what they mean by a triple A. There's class 1A, 1B, 1C. But speaking of the class of amiodarone, it's actually class 3 antiarrhythmetics, not class 1A at all. But although it's class 3, it has the effects of all classes 1, 2, 3, and 4 as well. But it's considered a class 3 antiarrhythmetic. So D is false. Then, not used in supraventricular arrhythmias. No, both ventricular and supraventricular arrhythmias are indications for amiodarone. So this is false. Then, regarding thrombolytic agents, second generation drugs have less fibrin specificity than first generation drugs. Now here, this is actually false. It's the other way around. The first generation drugs are streptokinase. Second generation drugs are altiplase and retiplase. They have more fibrin specificity. The second generation drugs have more fibrin specificity, meaning they only mostly activate the plasminogen, which is bound to the fibrin clot, not the free free plasminogen in the in the circulation is not activated. So because of that, the clot is dissolved, but there's no extensive systemic breakdown of the coagulation factors is not there with second generation drugs. So the first one is false. Second one, tissue plasminogen activator stimulates fibrinolysis in the absence of an extensive breakdown of the coagulation factor. So this as well. TPA is again fibrin specific. So just as I told you previously, it only activates the plasminogen which is bound to the fibrin clot. So this is true. Then streptokinase administered as an IV bolus dose within 30 minutes of reaching the hospital. Now, this is actually false. You don't give streptokinase as an IV bolus. We give it as an IV infusion, a slow infusion over 60 minutes. You should give streptokinase ideally within 30 minutes after coming to the hospital, or either within 12 hours of getting an MI, but it shouldn't be given as a bolus, it should be given as an infusion. Then, urokinase cannot be used to lyse pulmonary emboli. That's false. Urokinase can be used to lyse it. Altiplase activates only the plasminogen that is bound to the clot. That I mentioned previously. So, altiplase is a second generation drug which is highly fibrin specific. So, this is true. Then, salbutamol inhibits the release of TNF alpha from monocytes. Yes, so if you look at the modes of action of salbutamol in asthma, now salbutamol is a beta 2 agonist. Okay, so the main mode of action is it dilates the bronchi by relaxing the smooth muscles after directly acting on beta 2 receptors. So it's a physiological antagonism. We got this in a previous question as well. Then the additional modes of action are it inhibits the mediator release from mast cells. So histamine release is minimized. It inhibits the TNF alpha release from monocytes and also increases clearance of mucus by activating cilia. So salbutamol inhibits the release of TNF alpha from monocytes is true. Has a plasma elimination half-life of 1 hour. This is actually false. It has a plasma elimination half-life of 3 to 5 4 hours. Then can safely be used during pregnancy and breastfeeding. This is true. It can safely be used, but we also learned that in pregnancy, in premature labor also we give salbutamol. So yes, it can be safely given. Intravenous administration is important in the management of acute severe asthma. That again is true. In acute severe asthma, what we use is either IV or parenteral or the nebulizer forms. As a symptom reliever, what we use is the inhaled form or the oral form. This is true. Can cause hyperkalemia as an adverse effect. This is false. So salbutamol is actually used to treat hyperkalemia. It causes hypokalemia. So this is false. Then isoniazid is bactericidal against the rapidly multiplying organisms. This is true. Absorption from the GI tract is low, though it is widely distributed throughout the body. This again is false. It's rapidly absorbed in the GI tract. Should be co-administered with daily pyridoxine to prevent polyneuropathy. Again, yes. Peripheral neuropathy is a non-adverse effect of isoniazid. To minimize this peripheral neuropathy, we give pyridoxine for the patient. Daily pyridoxine is given. This is true. Then, it is absolutely contraindicated in HIV-infected patients. This actually now, isoniazid has a risk of hepatotoxicity. And if the patient is on antiretroviral therapy for HIV, the risk for hepatotoxicity is high. But isoniazid is not contraindicated in HIV patients because now anyways the HIV patients have a high risk of getting TB themselves. So they have to be treated for TB. They are given isoniazid to treat TB. So this is false. You have to be cautious regarding hepatotoxicity, but it's not contraindicated absolutely. Then hepatotoxicity risk increases with age. That again is true. Now I said isoniazid causes hepatotoxicity. Apart from that, the other anti-TB drugs which cause hepatitis are pyrazinamide and rifampicin. Ethambutol rarely causes hepatitis. Mostly isoniazid, pyrazinamide, and rifampicin cause hepatitis. And the risk of this drug-induced hepatitis increases with alcohol consumption. If there's a pre-existing liver disease, the patient is old, elderly, pregnant mothers, severely ill, or if the patient is having HIV infection. Then ondansetron has significant prokinetic effect. Ondansetron actually doesn't have a prokinetic effect. It doesn't have one. Uh, yeah, undergoes extensive hepatic first pass metabolism. Um, this is true. Because of that, we have to reduce the dose in severe hepatic failure. Can cause prolongation of the QT interval. Again, it's a side effect. That's true. Is effective in the treatment of delayed onset vomiting after chemotherapy. Ondansetron is used to treat chemotherapy induced vomiting, but that's only in the acute stages. After like 24 hours, it's not effective in treating chemotherapy induced vomiting. So this is wrong, not delayed onset. For acute conditions, you can. The effect is augmented by corticosteroids. Yes, the effect is augmented by combination with corticosteroids and NK1 antagonists. We call it triple therapy, being given in chemotherapy induced acute vomiting. Then cimetidine. So cimetidine is a histamine, the H2 receptor blocker. So this acts more prominently on gastric H1 receptors is false. It's on H2. Then undergoes extensive first pass metabolism when administered orally. The first pass metabolism of cimetidine is very limited. Okay, so this is false, but it does inhibit the hepatic enzymes. Although it's very limited, the hepatic first pass metabolism is very limited, it inhibits hepatic oxidative enzymes. So C is true. Can cause gynecomastia as a side effect. That's a non-side effect. That's true. Is less effective in the inhibition of nocturnal acid secretion than proton pump inhibitors. Now, cimetidine can also be used to uh, reduce both nocturnal as well as meal-related acid secretion, but proton pump inhibitors are the better ones. The reason being they irreversibly inhibit the hydrogen ATPase enzyme that acts as the final common pathway of acid secretion. And because of this, now the acid secretion can only return once there are new proton pumps being synthesized. So proton pump inhibitors are more effective than cimetidine. So E is true. Then regarding laxatives, fecal softeners are used as first line therapy for constipation in elderly. That's false because the first thing basically what you do is ask the patient to adjust the lifestyle habits, and then we start with a bulk forming laxative. We use fecal softeners later on if the stool is hard. So this is not first line. Bulk purgatives should be taken with adequate intake of fluid. This is true because the patient loses a lot of water with this bulk laxative, the bulk forming laxatives. You have to advise the patient to take water. Lactulose is a stimulant laxative. This is actually false. Lactulose is an osmotic laxative. Stimulant laxatives are recommended for bowel cleansing prior to colonoscopy. That's true. You use stimulant laxatives like sodium picosulfate, bisacardyl before surgeries, before colonoscopy to empty the bowel. Habitual use of laxatives known to cause hypokalemia. This is again true. Mainly with stimulant laxatives, the patients can get hypokalemia if they use for a prolonged time. That is true. Then 42. medicines causing kidney injury and their mechanism correctly matched. Acyclovir does cause a crystal nephropathy, that's true. Then diclofenac sodium causes reduced glomerular filtration, that is true. Spironolactone causes osmotic nephrosis, is false. The ones they had given for osmotic nephrosis was mannitol, immunoglobulins, and dextran. IV, intravenous immunoglobulins, mannitol, and dextran. Spironolactone doesn't cause an osmotic nephrosis. Then hydralazine causing glomerular nephritis is again true. Cipro causing interstitial nephritis is again true. These kind of questions you just have to buy heart. I mean, the drugs and the mechanism you have to buy heart them. Then furosemide mainly acts on the descending limb of loop of Henle. Now, furosemide is a loop diuretic. We know it acts in the ascending limb of the loop of Henle here. So this is false. It goes and blocks the sodium potassium dichloride transporters. Mainly circulates in unbound form. Now, furosemide, it's bound to plasma proteins. So because of that, it doesn't get filtered here in the glomerulus. So how they enter the tubules is they get secreted by an organic transporter at the proximal convoluted tubule. So it doesn't circulate in the unbound form, it's bound to plasma proteins. Has increased nephrotoxicity with concurrent administration with cephalosporin. This is true, both furosemide and cephalosporins are nephrotoxic. They are ototoxic as well, so ototoxicity will also increase in concurrent administration. Then is indicated in acute heart failure. That's also true. Now, in acute heart failure, there's this. You don't have to remember this for this paper, but you do give furosemide, that is Lasix, for acute heart failure. The main reason is now furosemide has this ability to cause dilation of the veins and increase the systemic capacitance. So because of that, it's given for acute heart failure and also for chronic heart failure as well. Other indications include pulmonary edema, nephrotic syndrome, chronic kidney insufficiency. Likewise, so the reason for giving it for acute pulmonary edema also, it's because of the venodilator effects mainly. All the diuretic action also contributes, but venodilator effect is the reason why we give it for acute pulmonary edema as well as acute heart failure here. Then precipitates hepatic encephalopathy in a patient with cirrhosis. That again is true. The reason being, now furosemide causes hypokalemia. So in a cirrhotic patient, hepatic encephalopathy may be precipitated. So we have to be cautious when giving it in cirrhosis. It's not a contraindication. We have to be cautious. Then, regarding warfarin, inhibits anticoagulant factors too. Now, warfarin inhibits, what it does is, as if you look at this, it inhibits the vitamin K reductase epoxide complex. So, thereby, the gamma glutamyl carboxylation of the factors 2, 7, 9, 10, protein C and SC is inhibited by warfarin. So, protein C and S are anticoagulant factors, so this is true. Known to cause thrombotic skin necrosis in individuals with inherited protein C deficiency. That is again true. The reason being, now I said warfarin inhibits the coagulant factors 2, 7, 9, 10 as well as protein C and S. So, anticoagulant protein C and S have a short half-life than factors, the clotting factors, the 2, 7, 9 and 10. So because of that, what happens is the factors which were formed before we gave warfarin are still there in the blood. So when the anticoagulant factors have a shorter half-life and they are getting inhibited by the warfarin, but still there's remainder of the previously formed procoagulant factors. Thereby, this causes a transient hypercoagulable state. So, if the patient also has an inherited protein COS deficiency, the patient has a higher risk of getting thrombotic skin necrosis. This is the reason why we give heparin or enoxaparin initially until you get the effects of warfarin, because the effects of warfarin to be there, it takes like 4 to 5 days. So within the first 4 to 5 days, we do something called bridging, where we also give heparin and enoxaparin. Then is mainly administered parenterally, and this is false. Now, anticoagulants are of mainly two types, oral and parenteral. Warfarin is an oral type. Patients on warfarin don't need frequent monitoring. This is false again. Warfarin has a very narrow therapeutic window. At the same time, there are several drug-drug interactions happening with warfarin. So even when you start a new drug to the particular patient, you have to monitor the INR. Now, INR is the one which sort of shows the effectiveness of warfarin. You have to monitor INR at least once every 4 weeks um, when you start a new drug per se. So this is false. Effect is rapidly reversed by PCC. PCC is prothrombin coagulant concentrate. I'm not exactly sure about the name, but this PCC contains, it's called 4FPCC. It contains these factors 2, 7, 9, and 10. So, for rapid reversal of the effects of warfarin, we can give 4FPCC. But this is not, I mean, all the times you don't give PCC. Usually, giving intravenous vitamin K to the patient is adequate. If you want to rapidly reverse the effects of warfarin, that is adequate. But sometimes, when we give 4FPCC, the reversal is more pronounced. It happens even quickly. But so we have to rapidly reverse the effects of warfarin if there's a severe hemorrhage or moderate hemorrhage. We can give either vitamin K or PCC. But if we only want to reverse slowly, we don't give vitamin K or PCC. We just withhold warfarin. That's enough. So effect is rapidly reversed by PCC is again correct. Then regarding iron supplementation, oral iron therapy should be immediately discontinued after correction of hemoglobin levels. Now, this is false. The reason being, now the iron stores are still depleted until around 3 months after you stop the after you correct the hemoglobin levels. So to replenish the iron stores, you have to continue oral iron for at least 3 months after correcting hemoglobin. Black stools is a common side effect, that is true. Hypersensitivity reactions to parenteral iron may be delayed 24 to 72 hours after administration. This is also true. There can be a delayed type hypersensitivity with parenteral iron. Ferric salts are better absorbed than ferrous salts. This is false. Now, even our iron preparations are found in the ferrous forms, ferrous sulfate, ferrous fumarate, ferrous gluconate, because they are better absorbed. So, it's not the ferric salts, it's the ferrous salts which are better absorbed. Oral iron shouldn't be given till 5 days after parenteral iron supplement. This again is true. Now, oral iron should be stopped at least 24 hours before you start IV iron, and then after giving IV iron for 5 days you don't start oral iron. This is the gap, 24 hours before giving IV and 5 days after giving IV, because you can get overdose. Basically, transferrin will be saturated completely and get side effects. Which of the following are correctly matched? So we don't have much time, so I'll be rushing. Methotrexate inhibits purine synthesis. So methotrexate, it inhibits both purine and pyrimidine synthesis. It's a folate analog, and thereby what it does is it inhibits dihydrofolate reductase, and thereby causes both purines and pyrimidine synthesis to be inhibited. Leflunomide, direct toxicity. Now, leflunomide, what it does is it inhibits this dihydroorotate dehydrogenase enzyme, which is the rate limiting step in this pyrimidine synthesis pathway. So it's not a direct cytotoxicity, that is false. It also causes pyrimidine synthesis inhibition. Then cyclophosphamide inhibits expression of IL-2 and TNF. Now, cyclophosphamide is an alkylating agent. So, if you look at this, what it does is it adds an alkyl group to DNA and thereby cause crosslinks in the DNA. And because of this cross-link formation, the DNA replication is not happening properly. Thereby, there will be apoptosis of the lymphocytes. So, T lymphocytes and B lymphocytes will be inhibited. So, this is again false. Mycophenolate mofetil inhibits pyrimidine synthesis. So, if you look at this, mycophenolic acid or mycophenolate mofetil, what it does is it inhibits this inositol monophosphate dehydrogenase enzyme, which is involved in guanosine synthesis pathway. So when this IMP dehydrogenase is inhibited, your purine synthesis is inhibited. Thereby, so it's not pyrimidine synthesis, it's purine synthesis. Then azathioprine inhibits pyrimidine synthesis. So if you look at this, what azathioprine does is it gets converted into 6-mercaptopurine and then 6-thioguanine. This 6-thioguanine, it goes and gets incorporated into DNA and thereby inhibits the DNA replication and also causes bone marrow suppression. So what happens is it gets incorporated and thereby inhibits the purine synthesis, not the pyrimidine synthesis. This again is false. Then levothyroxine is metabolized into active drug in the liver. This actually is true. There's a liver metabolism. High doses cause exophthalmos. Now, levothyroxine, when you give it in high doses, you will get hyperthyroid features, but not exophthalmos. Exophthalmos is only seen in Graves' disease. So, you will get the other features like palpitations, weight loss, likewise, but not exophthalmos. Plasma half-life is 24 hours. The half-life of levothyroxine was 7 days in euthyroid. So, this is false. In euthyroid, it's 7 days. But when the patient is hypothyroid, the plasma half-life is increased. In hyperthyroid patients, the plasma half-life is reduced. Should be discontinued in pregnancy, that again is false. In pregnancy, the requirement of the pregnant mother for thyroxine is higher because the baby also depends on the thyroxine taken by the mother. So you shouldn't discontinue it. You should actually increase the dose. Then poorly absorbed in the presence of food in the stomach. This again is true. Certain drugs also can reduce the absorption, affect the absorption, like antacids containing calcium and aluminium. So you have to take levothyroxine before breakfast, at least 1 hour before breakfast, away from other drugs as well, because the absorption is affected by food and certain drugs. Then carbimazole, competitive reversible antagonist of the tyrosine receptor. This is actually false. Now, carbimazole is a thionamide. What it does is, one thing, it inhibits the oxidation of iodide to iodine. It also inhibits the organification of iodine into thyroglobulin. And also, it inhibits the coupling to form MIT and DIT. So, they are the functions of carbimazole. It is not a competitive reversible antagonist of the tyrosine receptor. Induces hepatic drug metabolizing enzymes, that is true. Induce agranulocytosis as a type B adverse drug reaction, that is again true. Carbimazole can cause agranulocytosis and neutropenia as type B reactions, the bizarre type adverse reactions. Contraindicated in pregnancy. Now that is false. Carbimazole is actually, now there are, we learned about carbimazole and propylthiouracil, the main two thiamides. So usually propylthiouracil is preferred in the first trimester because the transplacental migration is comparatively lesser with propylthiouracil. Also in breastfeeding we prefer PTU, but in pregnancy only in the first trimester we prefer PTU. Otherwise, we give carbimazole to the patient, and also it's not contraindicated. You can still give, carbimazole is anyways preferred over PTU in other conditions apart from the first trimester, in breastfeeding, and also in life-threatening thyrotoxic conditions. For initial treatment of life-threatening thyrotoxic conditions, we give PTU. The reason is that PTU has an additional function of inhibiting the peripheral conversion of thyroxine in the tissues. That is why we give it in life-threatening thyrotoxic conditions. Otherwise, we prefer carbimazole. So this is false. Metabolized to methimazole in the body, that is true. Then, regarding oral hypoglycemic medications, sulfonylureas are known to cause weight gain. That is true. Sulfonylureas do cause weight gains. Now, if we look at this, sulfonylureas, meglitinides, thiazolidinediones, glitazones cause weight gain, while biguanides, like your metformin and alpha glucosidase inhibitors and incretin mimetics cause weight loss. They don't cause weight gain. You can't say weight loss, but they don't cause weight gain. So this is true. Metformin acts by inhibiting hepatic gluconeogenesis. That's again true. So if we look at the functions of metformin, mainly it acts in the liver by inhibiting hepatic gluconeogenesis, and also in the muscles and adipose tissue by increasing the insulin dependent glucose uptake, and also in the intestines by reducing intestinal glucose absorption. There are other functions as well, but these are the main three: liver, muscle and adipose tissue, and intestines. So this is true. SGLT2 inhibitors can cause genitourinary mycotic infections. Again, true, because they can cause glycosuria. Now, SGLT2 inhibitors account for 90% of absorption of glucose in the kidney. When you inhibit it, you get a glycosuria, thereby a higher risk of genitourinary mycotic infection. Then, sitagliptin can precipitate pancreatitis. That again is true. So apart from pancreatitis, it can cause nasopharyngitis and hypersensitivity as well. So I feel like it's important to remember this because now sitagliptin is a DPP4 enzyme inhibitor. Now this substance P is also a substrate for DPP4. When it's inhibited, you get high levels of substance P, and thereby you can get a nasopharyngitis. At the same time, kind of similar. Remember, the mechanism is not similar, but along with nasopharyngitis, remember pancreatitis and hypersensitivity. Then, GLP-1 receptor agonists are used in obesity management. That again is true. Then, prednisolone, yes, no mineralocorticoid effect. Now, if you look at this, there's this thing called approximate relative potency in clinical use. So, what this relative potency means is, now if we take hydrocortisone, there's a relative potency of 1 for the anti-inflammatory action and 1 for the sodium retaining action. That is, you like with a certain dose of hydrocortisone, the potency for anti-inflammation and sodium retaining is the same. But when we consider prednisolone, the anti-inflammatory relative potency is 4. That is, there's a 4 times more potency than hydrocortisone for prednisolone to cause anti-inflammation. And for sodium retaining, it's 0.8. That is, the power of prednisolone to cause sodium retention is 0.8 times that of hydrocortisone. So, so let's say we need 20 milligrams of hydrocortisone for a particular effect of anti-inflammation. Then for the same effect in prednisolone, for anti-inflammation, we are going to need 20 by 4, that is 5 mg. Likewise. So prednisolone no mineralocorticoid effect is false. We do have a mineralocorticoid effect with a relative potency of 0.8. Has a higher anti-inflammatory effect than dexamethasone. Now dexamethasone's glucocorticoid effect is 30. So that is false. Dexamethasone has a higher anti-inflammatory effect. Converted to prednisone, that's false. Prednisone is the one getting converted to prednisolone. Used in Addisonian crisis, that again is false. In Addisonian crisis, we use hydrocortisone IV. Now, we know in hydrocortisone, it's a 1-to-1 relative potency for anti-inflammation and sodium retention. So in Addisonian crisis, which is a primary adrenal failure, we have to replace both the glucocorticoids and mineralocorticoids. So we give hydrocortisone, which has a 1-to-1 ratio. Then has anti-vitamin D activity, that again is true. Yes. Then micropart. Regarding nasopharyngeal swab, specimens are used to diagnose viral infections, that is true. Specimens are transported at room temperature, no, that is false. I'm sorry. So the specimens have to be transported in viral transport mediums, refrigerated at 2 to 8 degrees Celsius. So this is false. Swab is inserted parallel to the flow of the nose. That is again true. It is done under sterile conditions. We don't take sterile precautions to take an nasopharyngeal swab. We just make sure it's aseptic. It doesn't have to be sterile. Rapid antigen test can be performed on the samples. That is again true. Then, regarding viruses causing CNS infections, herpes simplex can result in encephalitis. That is true. HSV virus can cause encephalitis. Enteroviruses are known causes of aseptic meningitis. That again is true. Pigs act as amplifier hosts for Japanese encephalitis. That again is true. Subcutaneous sclerosing panencephalitis is indeed a rare complication of measles. That is true. It is a rare complication, but it's very fatal. Acute flaccid paralysis is a notifiable disease. This again is true. It is notifiable because polio can present with acute flaccid paralysis. For polio. Then, which of the following statements is false regarding organisms causing UTIs? Proteus mirabilis is a facultative anaerobe. That is true. It can grow both in anaerobic and aerobic conditions. The most common infection by Klebsiella pneumoniae is UTI. Now, usually Klebsiella pneumonia mostly causes pneumonia. So, this is false. Pseudomonas aeruginosa colonies produce a distinct sweet smell. This is true. The smell is grape-like. It's sweet like grapes. This is true. Pseudomonas aeruginosa is resistant to a large range of antibiotics. That again is true. There's this intrinsic resistance in Pseudomonas for many antibiotics. Serratia marcescens can cause catheter-associated bacteremia. Again, this is true. It mainly causes these nosocomial coti, so catheter-associated UTIs. This Klebsiella pneumonia also mainly causes nosocomial pneumonias. Not UTIs mainly, it's nosocomial pneumonias. Then, which of the following are true regarding anaerobic infections? Anaerobic infections are causes of dental abscesses. That is true. Infections are mostly monobacterial. Usually, the infections of anaerobic bacteria are polybacterial, not mono. And this is false. Foul smelling discharge is seen. That again is true. Like anaerobic infections are very foul smelling. Then, swab from drainage of pus can be taken as a culture sample. Um, Now, usually, we can't take swabs from draining pus. The reason being the swabs can the anaerobic bacteria can die when getting exposed to the aerobic environment. So swabs are not successful for culture sampling. Organism cannot be identified using pus culture. This is again false. You can actually identify the organism by pus culture. Um, you have to make sure that the culture, you have to ensure anaerobic techniques are used though. Otherwise, the bacteria will die. Under anaerobic techniques, you can culture the organism. Then, regarding chlamydia, are obligate intracellular parasites. This is true. The obligate intracellular. Strain A can cause sexually transmitted infections. Now, in chlamydia, we have A, B, C strains. They cause trachoma. Trachoma is basically an eye infection. And we have D to K strains. They are the ones which cause non-gonococcal urethritis and sexually transmitted infections. Then we have L1, L2, L3 serovas. They cause lymphogranuloma venerum. Lymphogranuloma venerum. So strain A causes trachoma, not STIs. Then Reiter's syndrome is associated with chlamydia infection. This is correct. Reiter's syndrome is reactive arthritis. It can happen due to chlamydia infection. Doxycycline can be used as an antibiotic in chlamydial infections. That is also true. Chlamydia responds to doxycycline, which is a tetracycline. That is true. First pass urine is the sample of choice in male genital infections. This again is true. Now, usually for microbial culture, we take the midstream urine, but here for chlamydia, they are intracellular. So, because of that, we have to see the cells, the epithelial cells which have been infected. In the first void urine, you will see the epithelial cells, but in the midstream urine, you won't see much epithelial cells. That's why we take the midstream urine for other routine bacterial investigations, because the other type of UTI causing bacteria are within the urine. But chlamydia is intracellular, so we have to see the epithelial cells. So we take the first pass urine. So this is true. Then, regarding viral hepatitis, IgG is measured to diagnose acute hepatitis A infection. Now, IgG is, we know, it's usually used to measure the chronic infections, not acute. This is false. In acute infections, what we should measure is IgM levels. Then, main method of prevention of hepatitis E is vaccination. Again, false. Hepatitis E is a infection transmitted via the fecal-oral route. So mainly, it's safe water and good hygiene are the main methods of preventing hepatitis E. Vaccination is also found in some countries, but the main methods are the safe water and good hygiene practices. This is false. About 90% of neonates who got hepatitis B via vertical transmission develop into chronic states. That is true. Now, we know hepatitis B and C are the ones which go into chronic state mostly. Even with that, hepatitis C is more associated with chronicity than hepatitis B. Then, hepatitis C is predominantly sexually transmitted. Hepatitis C is actually mostly transmitted through body fluids. Sexual transmission is minimal. So this is false. CMV causes hepatitis. That is true. So apart from the classical hepatitis viruses, there are certain other viruses like CMV, EBV, HSV, yellow fever virus. They also cause hepatitis. Then, regarding varicella zoster, transmission mainly occurs through direct contact. That is false. It's mainly through the airborne route. It's not the direct contact mainly. Then infection is symptomatic in majority. That is true. Yes, it is symptomatic in majority. Virus is eliminated from the body on recovery. That is false. We know that it stays latent in our body. Varicella zoster virus stays latent in our sensory ganglia, so it's not eliminated on recovery. Produces lifelong immunity is true actually. Um, Patients who had got chickenpox once, they won't get it again. So it does produce lifelong immunity. Chickenpox vaccine is included in the national immunization program. It's not. There is a vaccine, but it's not included in the national immunization program. Advantages of live attenuated vaccines compared to inactivated vaccines are they are more immunogenic. That is true. Now, in live attenuated vaccines, the whole pathogen is there, but the pathogenicity is not there because it's attenuated. Okay, so because of that, compared to inactivated vaccines, the the immunogenicity is higher in live attenuated vaccines. Then, can revert to virulent type. This actually is true. I mean, the live attenuated vaccine has a risk of reverting to virulent type, especially in immunocompromised people. It can get reverted, but it's not an advantage. So we can't consider it as a true answer here. It's false, but there is a risk of reversal to the virulent type. Lesser number of doses is needed. That again is true. We need repeated booster doses for inactivated vaccines, but not for live attenuated vaccines. Can be given in pregnancy. That again is false. Live attenuated vaccines are contraindicated in pregnancy. Can induce mucosal immunity depending on the route of administration. This is true. For example, OPV, the oral polio vaccine, can induce mucosal immunity. It's a live attenuated vaccine. Then, regarding hypersensitivity, Graves' disease is a clinical manifestation of type 2 hypersensitivity. This I said previously as well. Graves is type 2, Hashimoto's is type 4. This is true. You get TSI, thyroid stimulating immunoglobulins in Graves' disease. Then, onset of anaphylaxis is 24 hours after exposure to allergen. That is wrong. Anaphylaxis is actually an acute, rapid manifestation. Drug induced hemolysis occurs in type 2 hypersensitivity. That is true. You get antibodies getting deposited and causing the hypersensitivity in type 2 hypersensitivity in drug induced hemolysis. Vasculitis is the predominant feature of the type 4 hypersensitivity. Now, usually in vasculitis, that it is type 3 hypersensitivity. The immune complexes go and mediate the hypersensitivity. It's not type 4. Type 4 is by T cells. T cell mediated hypersensitivity is type 4. Then cytotoxic T cells has a main action in type 1 hypersensitivity. That again is false. I said T cell mediated one is type 4. Type 1 is mediated by IgE. Then the last question regarding pneumocystis, it is an opportunistic infection. That is true. Now, pneumocystis caused by pneumocystis jirovecii. It's an opportunistic infection mainly seen in immunocompromised, like HIV patients. So, it's opportunistic. That's true. A productive cough is seen. That's false. It has a dry, non-productive cough. Ground glass appearance is seen in chest X-ray is true. 5-day antimicrobial therapy is adequate. That again is false. 5 days is a very short time. You have to give it at least for like 21 days. A prolonged course have to be given for pneumocystis. Then, antibacterial prophylaxis is recommended in the immunocompromised. This again is true. You do give antibacterial prophylaxis because now the patients who get pneumocystis are immune compromised, and for them you give antibacterial prophylaxis. So that's all for the paper. If you have any question, you can send me a message. So I'll look into it and reply. Okay, so Argesh, shall I end? Okay. Okay.